Good evening and welcome to Doctors on Call. I'm Dr. Ruth Westra from the Department of Family Medicine and Community Health at the University of Minnesota Medical School Duluth. And tonight we're going to talk about eye problems. We'll be glad to take your questions about cataracts, glaucoma, macular degeneration, and other eye problems you might be concerned about. The success of this program depends largely on our viewers, so don't be shy. Call with those questions and we'll do our best to answer them. The number to call locally is 218-788-2844, and the toll-free number is 1-877-307-8762. I'm pleased to welcome our panelists this evening, Dr. Lasik Surgery, an ophthalmologist with Relf EyeCare Specialists in Hermantown, Dr. Joseph Morehouse, an ophthalmologist with Essentia Health Duluth Clinic, and Dr. Timothy Quinn, an ophthalmologist with St. Luke's Miller Creek Medical Clinic and St. Luke's Hibbing Clinic. Our medical student volunteers answering the phones tonight are Ann Bergstrand from Alexandria, Minnesota, Courtney Moores of Northfield, Minnesota, and Angie Volkort, also from Northfield, Minnesota. And now on to tonight's program on eye problems. So maybe we should just kick it off just with a few questions before the questions come in. And Dr. Graham, tell us about routine eye care. When should we go to the eye doctor?
Well, a lot of the answer to that question depends on probably your health. I think people who have more significant medical concerns need to have their eyes checked more often. I think every child should probably have a good eye exam at once during their school years. Most adults probably every few years. And then when you get to be over about age 60, sometimes we'll recommend every year annual eye exams. A lot of it also depends on whether you wear glasses or not. People need to update their glasses kind of regularly, so they might need eye exams more often.
Great. How about with diabetes, Dr. Morehouse?
Diabetics need an annual dilated exam, at least, depending. And then if they have end up having diabetic retinopathy, sometimes they'll be seen even more often than that.
So we have a prop with us. Dr. Quinn, do you want to walk through the prop a little bit about the parts of the eye?
Sure. So I generally try to think of the eye as built much like a digital camera at home with lens structures in the front, and the eye basically consists of the cornea and the lens. The body of the camera is also the cornea, but also the sclera, the white of the eye, which extends all the way around the exterior of the globe. The diaphragm of the camera, in effect, is the iris, the colored part of your eye, and the aperture is the pupil, which is just a hole to let the image or the light enter the eye. The film that takes the digital photo in the eye is the retina, which feeds wiring into the optic nerve back to the brain. Around or behind the retina is the choroid, which is the most vascular part of the body and provides the nutrition for the retinal function, as well as cooling effects and heat removal. Of course, the eye is also an organ, and it needs to maintain itself. The fluid that fills the eye is basically produced in the ciliary body, just near the anterior part of the eye, and drains out through the corner between the colored part, the iris, and the cornea, the clear window in the front. That's the basic anatomy.
So lots of things can go wrong potentially, and hopefully
Certainly.
everything works well.
Usually.
Usually, good. Well, talk to us, Dr. Morehouse, a little bit about glaucoma. To tell us like normal pressures and a little bit about what you should watch for.
Glaucoma is, excuse me, is actually a family of diseases. But basically the glaucoma is a situation where the pressure in the eye is too high for the health of the optic nerve. And what can happen then is that damage can occur to the optic nerve that typically is very slow over time, although in rare cases can go rather rapidly. Typically it causes loss of peripheral vision first, and many times in a kind of an insidious way. So that I have actually seen people that have lost maybe 90% of their peripheral vision before they even realize that they have any sort of problem.
So a caller called in a little earlier about laser treatments for glaucoma. Can you talk about that, Dr. Graham?
Sure. There's a variety of ways to treat glaucoma. Usually we start with topical eye drops to try to lower the eye pressure and protect the eye from further damage. In some cases, we'll choose to do a laser procedure to try to open up the drainage system of the eye and allow more fluid to exit the eye and to lower the pressure in that way. In some cases, these are patients who can't put eye drops in, and so having a laser done is a good alternative. Some folks don't tolerate eye drops well. They have allergic reactions or sensitivities. Some folks just don't want to take eye drops or can't remember to take them, and laser can be a good alternative there. Sometimes we use it just to avoid having to do more invasive surgery too.
Well, a lot of questions are coming in. Let's start with this one from Duluth, Dr. Quinn. How important is it to wear sunglasses when you're outside?
Well, in general, we would consider it very important. Ultraviolet light, which is generally blocked by your spectacle if you happen to wear prescription glasses as well, should have ultraviolet coating on it. You can verify that with your optician. But ultraviolet can cause damage to the surface of the eye. It contributes to cataract formation as well as skin cancers near the surface of the eye and the eyelids and such. Sunglasses would also protect from that because they have UVA and UVB protection. Certain wavelengths of light may also raise the risk of macular degeneration or contribute to the formation of macular degeneration, particularly blue wavelengths, so either gray or brown sunglasses, amber tinted, should help reduce the risk or delay the onset of macular degeneration. Unproven, but possible. So in general, I think sunglasses when outdoors are a very good idea.
For prevention, mostly.
Yeah.
Dr. Morehouse, a caller from Duluth asking about what causes potentially sharp pain in eyes. If you can talk about that a little bit.
That could be a number of things, I suppose, anywhere from actually having a foreign body, like a hair or an eyelash in there, to dryness, to sometimes people get spontaneous scratches on their corneas. Another cause that comes to mind is little calcium deposits on the inside surface of the lids, so there could be any number of causes to that. The most common, I think, would be the dry eyes.
So we do have a question about dry eyes. I think we talked about that a little bit earlier before the show started. Dr. Graham, maybe talk a little bit about dry eyes and what we potentially can do for that.
Dry eyes are just very, very, very common, especially in Minnesota in the winter. Your eyes make tears. Your tears have oil and mucus in them that help prevent evaporation. And if you're missing any one of those components, you can have dry eyes. As we get older, we make less volume of tears. Certain eye conditions can cause you to have less oil and mucus in your tear film. And so what liquid tears you do make might not work well either. And then in the winter, the air is dry and your tears evaporate more quickly. So really, dry eyes are very, very, very common. A lot of symptoms like burning, tired feeling eyes, computer fatigue often is dry eyes. Sharp pains can be dry eyes. If you get a dry spot and your lid is rubbing it, it'll hurt. Moisturizing drops are available over the counter, and folks who have any of these symptoms should use them regularly.
Excellent, thank you. Dr. Quinn, a caller from Meadowlands asking about when do you worry about floaters?
We worry about floaters whenever there's a change. New floaters, greater in number associated with flashes, curtains, bubbles, anything new in the vision, whether it's a floater or another phenomenon, should incite a ophthalmic exam.
Dr. Morehouse, caller from Duluth asking about Lasik surgery. Anything new about long-term studies regarding Lasix?
That's a good question. I would say that I don't know what's the latest studies are, but LASIK in general is a safe and successful surgery, and in general, in appropriately selected patients, people tend to do well. I think that we've learned a lot over the years about who is a good candidate for LASIK and who is not, and so the chances of having a serious complication from any refractive surgery are less than they used to be, and they were never very high.
Still a fairly common surgery, you'd say, or?
I think that there was kind of a wave of LASIK that lasted probably from about 1995 to about 2005, and I think that it's more of a trickle now.
Mm-hmm. Well, Dr. Graham, a caller asking about eye complications with multiple sclerosis. Maybe you could talk a little bit about that.
Sure. Multiple sclerosis is a disease which affects sort of the insulation or the coating on the on nerves. Whenever that insulating layer gets a lesion or a defect in it, that nerve will not conduct impulses well, and if that occurs in the structures of the eye, you can have eye symptoms. So a lot of MS patients, sometimes the first sign of MS can be a sudden loss of vision in one eye. It's often painful. The vision will often return with time. We call that optic neuritis. And sometimes that will prompt testing that leads to the diagnosis of multiple sclerosis. Multiple sclerosis patients can also have trouble coordinating their eyes, so double vision or just a feeling of dizziness or instability in their vision, especially if they have advanced multiple sclerosis.
Thank you. Dr. Quinn, a caller from Saginaw. Difference between uveitis and iritis.
Sort of like the difference between Minnesota and Duluth.
Yes.
Uveitis refers to, grab the diagram again. So we talked about the layers sort of the eye, and that you've got the sclera, the white on the exterior, the retina on the interior, and the choroid in between. The choroid is contiguous with, or it is the same structure basically as the pars plana and ciliary body and iris. All those layers are called the uvea anatomically. So any inflammation-itis of the uvea, whether it's the choroid, the pars plana, the ciliary body, or the iris, is uveitis, whereas iritis implies it's an inflammation of the iris. So if we see inflammation that's just in the very anterior part of the eye, we generally call it iritis or anterior uveitis. And then any inflammation from the iris all the way back to the choroid, we would call uveitis.
Oh, thank you. That was very helpful. Dr. Morehouse, a caller from Duluth, calling about progression of cataracts. What's the typical progression of cataracts, and when do you need surgery?
The typical progression of cataracts is very slow. You can go easily 20 years from initial diagnosis of cataracts to the point where they actually become a problem. The timing of surgery is based on when they begin to interfere with your life, basically when you get to a point where your vision is such that that you're unable to do certain things that are important to you, whether that be driving, reading, watching TV, or what have you.
And we have quite a few techniques that keep people as an outpatient for the cataracts now, most commonly.
Virtually all cataract surgery is outpatient, same-day surgery, yes.
Dr. Graham, a caller from Britt, about what are solutions for eye allergies?
Oh, well, I guess the most basic solution would be try to avoid that which you are allergic. That's not always possible. You can use the same oral medications that you would use for allergic symptoms such as runny nose or sneezing will also work on the eyes. You can use moisturizing drops, just artificial tears would flush the eyes and help soothe them. You can use over-the-counter allergy drops, and there are some good ones that are over-the-counter. There are some ones that I prefer patients not use, such as the eye whiteners, like the Visine, Murine. They don't get at the root cause, whereas the antihistamine allergy drops, such as Aloe or Zatador, get at they actually block the histamine reaction and work a little better. Cold compresses and good old Tylenol can help too.
Good, good. Well, Dr. Quinn, a caller is asking about, can you talk about macular degeneration and why you get it? The eye is helpful, isn't it?
So again, going back to the basic anatomy, the retina is the film that takes the picture in the back of the eye. This little indentation, which I'm not sure will come through on the television, is the center of the macula. In effect, the way mammal retinas are structured, the opposite of an octopus or certain amphibians, the receptors receiving the photoreceptors are on the outer aspect of the retina rather than the inner, and all the wiring is in the interior aspect. And in the macula, we push that out of the way so we get a clearer picture. So when you're looking at your TV screen right now, you're looking with your macula. We get finer detail in that. And there's evolutionarily, there's a lot of argument about why we've decided to put those on the outside and get a less clear image for our peripheral retina, and an octopus or a squid decided to, or evolved higher clarity, but perhaps less precise processing throughout. However, so that's the macula. That's the center area, the most important part for us humans, because we recognize faces, watch TV, read letters with the macula. Macular degeneration means that the macula is degenerating and it's not working very well. That can manifest in difficulty reading letters, difficulty recognizing faces, and tends to be a slow progression. For 90% of cases, around 10 to 15% can move rather quickly. And in the worst case scenario, you lose that central vision, but it generally won't affect much of your peripheral vision. You can get patches in the peripheral vision lost, but usually so small that that it won't affect function. What causes it? There's genetics involved. There's light toxicity. Antioxidant deficiencies may contribute to it, although that's very poorly proven. But it's the oxidant stress of light, usually in the visible wavelengths, thought largely to be blue by certain basic science studies, but that's, again, poorly proven. And that damages the certain layers of the retina and choroid, leading to the degeneration. That answer all that question?
Very good. No, that's very helpful. We're getting a lot of questions, so we probably aren't going to be able to cover all these. Yeah, Dr. Morehouse, a caller from Cloquet asking about rheumatoid arthritis and if it can affect the eyes and what are the symptoms.
Rheumatoid arthritis can definitely affect the eyes. The most common manifestation would be fairly severe dry eyes that we've talked about before. Less commonly, but perhaps more dangerous, would be inflammation on the layers of the eye. The classic one would be scleritis, which would manifest itself as a kind of a deep aching pain associated with the red eye that can be a serious complication and even potentially a vision-threatening complication of rheumatoid arthritis.
Excellent. This is an interesting question, Dr. Graham. Photographer asking if it's damaging to the eyes to take pictures of sunrise, dangerous to look at the sun through the lens.
That is an interesting question.
Yeah.
I would think that if you're looking through the lens, you would have UV protection through by way of the lenses.
Yeah.
Digital photography, however, is different. Although you're not looking right at the light, you're looking at your camera. So I think you would be protected. You can always wear prescription glasses, have ultraviolet protection in them, as Dr. Quinn said, and that would help filter light too.
Yeah, that's an interesting question. A question, Dr. Morehouse from Grand Rapids, about flashes, like a strobe light in the eyes. Are those common? People complain about that very often.
Those are common. Probably the as far as the concerning flashes would be just intermittent ones that seem to happen with eye movement. Sometimes that can be related to traction of the vitreous jelly that lives in the back cavity of the eye on the retina and can indicate or can be at least a risk factor for a torn retina. There are other type of flashes that people describe, kind of zigzaggy lights that may be more of a ophthalmic migraine type situation, which are not as concerning.
Dr. Quinn, a caller from Cloquet about advantage of using lutein or Ocuvite. You know, sometimes we use vitamins. Any comments about that for macular degeneration? Or
So I think the caller is referring to the age-related eye disease study and the second version of that, the ARIDS for short, and the ARIDS 2 studies. While, as I vaguely mentioned with macular degeneration, antioxidant oxidation is perhaps part of the cause of macular degeneration. No studies have proven for the general population that vitamins delay cataract, glaucoma, or macular degeneration. However, the ARID studies have shown that high doses of AC, zinc, and now lutein and zeaxanthine may help to slow down the progression of moderate to severe macular degeneration, with little benefit being found for even mild, oddly enough. But still, for someone who has macular degeneration, we recommend something on the order of Ocuvite or Preservision, with or without lutein, depending on the scenario.
Dr. Graham, a caller from Hermantown asking about pink eye. Does it always require a prescription? An antibiotic or drops? Or
No, it does not. And antibiotics are probably overused in pink eye, or what we call conjunctivitis. Most conjunctivitis is probably a viral infection. Goes hand in hand with most upper respiratory infections that are also viral. And usually a person's immune system will clear it on their own. However, if there is a really significant discharge or some other symptoms, it might be bacterial, and in that case, antibiotic would be beneficial. Most viral conjunctivitis will start to clear within 3 to 5 days, whereas a bacterial conjunctivitis may or may not clear on its own.
Well, thank you. Dr. Morehouse, a caller from Grand Rapids about retinal detachment. Causes briefly about retinal detachment, what you can do to prevent it.
Most retinal detachments are related to development of a tear in the retina. Probably the two major causes of that would be trauma, so an injury to the eye, getting punched in the eye, or blunt trauma to the eye. The more common cause of that would be, I'm going to get the eyeball model out here. The back of the eye here is filled with a jelly called the vitreous, and as part of the normal aging process, that vitreous jelly, which is attached loosely to the retina when we're born, that vitreous jelly tends to collapse in toward the center of the eye, and in some cases, if there's a tight connection between the retina and vitreous, when it collapses, it can actually pull the retina apart, causing a break in the retina, which then can allow fluid to get underneath the retina, and then the retina can come off the back wall of the eye like wallpaper with bad glue.
Excellent. Dr. Quinn, just a few more moments here, so keep it brief. A caller from Duluth asking about tear ducts, how they can be unplugged if you have a plugged tear duct.
Well, it depends on which tear ducts we're referring to. So you've got lacrimal ducts from your lacrimal gland to the fornices, the surface area of the eye. Those can be blocked, leading to inflammation, swelling, infection. That's not very common, so I suspect we're talking about someone with a tearing issue whose drainage ducts, the nasolacrimal ducts where the tears drain into the nose, are blocked. If it's congenital, most will fix themselves. If it's a baby born with that problem, somewhere in the first 6 to 12 months, that will often go away. Massage, antibiotics may be required in the process, but that will usually often fix itself, or we can go to surgery and probe to open that up. In an adult, many causes, but so occasionally, again, probing may open things and irrigating may open things adequately, but most often you go on to a surgical procedure to create new ductwork from the eye to the nose for the tears to drain better. You just have to create a new space, but it depends on the exact scenario.
Any other comments to add about that?
No, I think you covered it pretty well.
Okay. Right. Just a quick question. This is a tough one because it's pretty complicated, but double vision, causes of double vision, Dr. Graham, we're going to have to go fast.
Go fast. That's a complex one.
Yeah.
There are lots of causes for double vision. Double vision happens usually when both the two eyes aren't working together, and if they're not looking at the same focal point, they will see two different things, and you'll see double. Okay. So there are 3 nerves that control the eye movements in general. If any one of those nerves becomes damaged, you can see double. Children can be born with misaligned eyes too, and that can be a problem.
Good. Well,
guess
good.
we're out of time.
Sorry, that was a fast
That was
one
too
at
quick.
the end there. Sorry about that. I want to thank our panelists, Dr. Lisa Graham, Dr. Joseph Morehouse, and Dr. Timothy Quinn, and our medical student volunteers, Ann Bergstrand, Courtney Moores, and Angie Volkert. Please join Dr. Ray Christensen next week for a program on stroke and other neurological problems, when his panelists will be Dr. Nick Itzen, Dr. Emily Onello, and Dr. Ruth Thompson. Thank you for watching. Good night.